to make a lasting impact on health and wellness in Texas. Our mission is to advance the PA profession in Texas through advocacy, professional development, and engagement. As a courtesy to our speaker, please mute and silence all devices, beepers, phones, etc. You may not sit on the floor or along the wall. We have plenty of chairs, so please use them. As a reminder, please adhere to the code of conduct. Please remember that there should be no photography or videos taken of the session. This educational session may contain discussion of unpublished and/or investigational uses of agents that are not indicated by the FDA. Therefore, before prescribing any of these medications, please review the complete prescribing information, including indications, contraindications, warnings, precautions, and adverse effects. The information and content presented are that of the contributing faculty and do not necessarily represent the views of the TAPA or AAPA and/or any named commercial entity providing financial support. TAPA and AAPA supports eliminating patterns of conceptualizations of race or ethnicity as a proxy for biology or genetics in medical education, clinical practice, and policy. Finally, please remember to evaluate each CME session for the conference app by October 7th so you can claim your CME credit. As a brief history, the 2009 TAPA support for expanding full practice authority for PAs laid groundwork for future wins. By 2021, PAs gained the ability to prescribe Schedule II medications. These advancements underscore the importance of persistent advocacy, even when progress seems slow. We are grateful to you, our members, for helping us get here and influencing the steps we will take next year in Austin. Now, I'd like to welcome our faculty speaker, PA Jonathan Ives.
Thank you. Good morning. Sorry about the technical problems. So we're trying to test out recording these slides so that they could be available later. So that's what we're messing with up here. I'm Jonathan Ives. I'm a pulmonary critical care PA. I've been with this group, Texas Pulmonary Critical Care, for about a decade now. And I also serve as the Chief Strategy Integration Officer, so like the head of strategy and business development for my group. I'm an adjunct faculty at UNT Health Science Center. I'm the director for the Pulmonary Embolism Response Team at my hospital. So it's a THR facility downtown Fort Worth. And I'm a TAPA director at large. This lecture on pulmonary embolism management is hopefully going to be kind of like a gap filler. There's been a lot that has changed in the last 15 years, even 10 or 5 years. And so I'm going to review a lot of the clinical trials. I'm going to review very briefly about pulmonary embolism itself. And so one of the big things I want to talk about today is how we classify the various types of pulmonary embolism. We're going to talk a lot about submassive PE, how we identify that. We're going to talk about how we diagnose this and what types of workup do we do for these patients. We're going to talk about what management strategies and maybe what are some of the newer management strategies, right? So the catheter-directed techniques, embolectomy, ECMO, for example. And we're going to also spend quite a bit of time talking about the multidisciplinary role that we can fill. And this is really the talk that I want to send you home with, is that as a PA, I have created this hospital-based program that has lots of specialties and is really helping to improve the management of these PE patients. And so we're going to talk a lot about this. The multidisciplinary team, that's what PERT is. And I'll talk about what it is and why we have to do it. And the way that we're going to talk about this is I'm going to try and frame this clinically around a couple of cases, so it feels very real and not like up in the clouds. So we begin, this is a case, this first one is a 26-year-old woman. She has a history of PCOS, and she came to the hospital with 2 days of shortness of breath. And she called EMS after a syncopal spell with some seizure-like activity. So just of note, the shortness of breath she's been having was associated with the chest pain. The only medication she's taking is an oral contraceptive. She drinks socially and she's a never smoker. So when we start to look at, kind of an interesting side note, her dad also had a massive PE, and he required thrombolytics. So there's clearly a family hereditary pattern here. We look and you can see she's tachycardic. She's on 6 liters of oxygen, and her temp is 99. On physical exam, she's in moderate distress. She's tachycardic, but otherwise her exam's fairly normal. She has quite a few abnormalities on lab work. You know, she's got a mild AKI. She's hyperglycemic. You can see that her serum bicarb is fairly low, and that's kind of an aside, not what we're talking about. And you can see that her troponin and BNP are both elevated. And by the way, this is, if you don't use high sensitivity troponin, just suffice it to say her troponin and BNP are both elevated. So we get an x-ray. I know you probably can't see it super great, but this is a pretty unremarkable x-ray. And so for a 26-year-old with acute onset of shortness of breath, her risk factors, say having cardiac ischemia, she has nothing else really going on, and a clear chest x-ray like this, pulmonary embolism is a very high up on the differential. She gets a 12 lead, and I'll highlight a few things on this. So first of all, the most common finding that we see is a tachycardia. She is tachycardic, her rate's 136. And she has a few things that are quite a bit more specific to pulmonary embolism and acute right heart strain, because we know tachycardia, I'm probably tachycardic, so I was trying to get this thing to work, right? So more specific findings are this incomplete right bundle, if they have a complete right bundle, and if they have flipped T waves in these precordial leads, V1 and 2. And so you can see that her T waves are flattened or flipped in these leads, and this is more sensitive than the classic S1Q3T3 we all know, but it is still very specific for acute right heart strain. She does actually have a big prominent S wave in lead 1. She has a Q wave in lead 3, and she has a flipped or flattened T wave in lead 3. So I would classify this as a S1Q3T3. So of course she gets a CT, and you can see she has the arrow signs, which I'm just pointing out all these clots that she has. So she has bilateral acute pulmonary embolism. And on the CT scan itself, you can see that her right ventricle is larger than her left ventricle. And this is indicative of right heart strain. And she also has this, what we call mild flattening of this interventricular septum, which is again indicative of right heart strain. And we're going to come back and talk about some of these things and why these things are significant. She gets an echocardiogram, and that's not the best picture of it, but suffice it to say that she has a big dilated hypokinetic right ventricle, and her interventricular septum is bowing out with systole. Okay, so that's the first case. The second case is a 75-year-old gentleman. He's hypertensive. He has hyperlipidemia, diabetes, and he's had a DVT previously. And so he comes in, he's had a week of shortness of breath. He did a COVID test at home that was positive, and he came in to the ER because his shortness of breath acutely worsened. So, medication-wise, he's not on anticoagulation. He takes aspirin, Lipitor, Synthroid, Decadron, and Prilosec. The Decadron was just for the COVID. He drinks a glass of wine a day. He's a former smoker. He has a 10-pack year history. And so, here we have someone that's short of breath. They have COVID. And, a physical exam, you can see he's again tachycardic. He's tachypnic. He's also on 6 liters, and his stats are 92%. Lab-wise, pretty unremarkable, some mild hyperglycemia. And you can see that, again, his troponin and BNP are both elevated. So when we look at his x-ray, right, this does not look like, a diffuse lung injury or ARDS that we might worry about sometimes with COVID. pretty clear x-ray, to be honest with you. So his increased oxygen requirements, the fact that he's had a PE before, or a DVT before, recent COVID, these things are all making a PE very likely. And you could see that he's also tachycardic. His rate's 135. He also has an incomplete right bundle, and he has these split flattened T waves in the precordial leads. He does not have the S1Q3T3. So, of course, he gets a CT, and we could see he has bilateral pulmonary emboli. He has a really extensive clot burden, and he has a big dilated right ventricle with flattening of the interventricular septum. So again, you can see there's his right ventricle, and the interventricular septum is flattened out. And so he gets an echocardiogram as well, and now you can see this much more clearly. So here's his right ventricle and left, and his right ventricle is dilated, has a global hypokinesis. It did have like preservation of the apex, it's what we call McConnell sign, moderately reduced RV systolic function. Put together, these are all like acute right heart failure things. You can see his left ventricle is, you know, got some diastolic dysfunction, but for the most part, this is unremarkable. And so I'm using these two cases to kind of frame our discussion here. Like, what is the most appropriate management for each of these people? Should we just put them on anticoagulation? Should we give them systemic thrombolytics? Should we do one of these new catheter-based techniques? Should we cannulate them for ECMO? Should we do none of the above? Maybe we want to do something else. And what I would hopefully we could all agree on, at least, is that there's probably pros and cons to each of these approaches, right? You push, you know, thrombolytics on somebody, and that can affect decisions we make later. You just do anticoagulation alone, and maybe they don't have as good of an outcome, or, you know, these various types of things. And this may not be static, right? What's best in one moment may change as the clinical picture changes itself, okay? So with that, we're gonna put that in the back of our mind, and I'll come back to these cases at the end. So venous thromboembolism, it's a spectrum of disease. And so it's very common. It occurs 1 out of 1,000 people a year, and it increases significantly with age. So by the age of 80, we're seeing 5 out of 1,000. And it's the third most common cause of cardiovascular death, and it's the most common cause of preventable inpatient death. So collectively, we have two things that make up this spectrum, venous thromboembolism. We have pulmonary embolism and DVT. And so we recall, right, coming out of the left ventricle, we have these arteries that are covered in smooth muscle. This gives us all this vascular resistance. But the veins aren't like that. They're just like a low pressure reservoir that hold, you know, 60-something% of our blood volume. And the pulmonary vasculature is the only place, right, that receives all the cardiac output, right? So we push from the right ventricle into the pulmonary vascular bed, and at any given time, 9%, maybe more, of our blood volume is sitting there in that pulmonary vascular bed. So when we get an obstruction in that, in those pulmonary arteries, it's a PE. When we get, you know, an occlusion here, a thrombus in the deep veins of the leg, we call it a DVT. And of course, they're intricately linked. Okay, so the DVT typically begins, there's like a little small clot, typically maybe a site of an injury, maybe we have trauma, maybe there's a catheter there, who knows. But this thrombi can grow and propagate, and then it has the potential to embolize and move its way into the pulmonary arteries, where it kind of gets stuck in this pulmonary vascular bed. So, you know, the way that I just described this is what we call thrombotic pulmonary embolism. And so that's when, you know, again, we kind of talk about this like it's only lower extremity, but we could also have an upper extremity clot, and they're tightly linked. Of course, it does not have to be thrombotic material. It could be fat, tumor cells. We manage those things very differently. We're not really talking about, you know, non-thrombotic pulmonary emboli. Most of these pulmonary embolisms, they come from what we call proximal DVTs. So a distal DVT would be like down in the calf, and, you know, as we move up, you know, like we have several veins, the popliteal, the femoral, and the iliac, And these iliofemoral clots down into the popliteal, they account for the vast majority of pulmonary emboli. And like I mentioned, we only really kind of think about lower extremity clots, but they can happen in the upper extremity. And just to take home, right, it's like if there's a clot in the axillary vein or more proximal, well, we should probably be anticoagulating that, okay? And the axial is just this, confluence of the brachial and basilic veins, okay? So the pulmonary embolism. So what's happening here is that the pulmonary embolism creates this mechanical obstruction, right? It's just blocking the flow of blood from the right ventricle to move back through, get oxygenated, and then move into the left side of the heart. And this is going to increase this obstruction. It immediately increases what we call the pulmonary vascular resistance, right? And this concept of vascular resistance is, how much do we have to push to get blood to come out of this right ventricle? And so, this is putting a lot of strain on my right ventricle as it's pushing against that clot here. And once I get enough of an occlusion, so maybe, about 50% or more, what I start to see is that the pressure here on my right side, the PA systolic pressure starts to go up. And this is significant because this is an acute thing that just happened, right? This thrombus, it broke free and it embolized here. And so there's really not any time at all for this right ventricle to hypertrophy. And so the right ventricle has very low afterload. And, in someone that does not have right-sided heart failure, we typically don't see, for example, a PA pressure that goes over 55, okay? And once we hit that point, we start to go into acute right heart failure. This is the thing, this acute right heart failure, that ends up causing us the disease and all of the mortality associated with pulmonary embolism. So, here we're squeezing, right? This is, part of this compensatory response. We release catecholamines, we become tachycardic and tachypnic, our contractility goes up, and we start to see, as this backflow, this vascular resistance is pushing back, the RV end diastolic pressure starts to go up. And this starts to make my tricuspid valve leaky, okay? And what's happening here is that we're kind of getting overwhelmed. The right ventricle itself is under a lot of wall tension, and I start to get ischemia in my right ventricle. So, just to walk through the steps, I have this mechanical obstruction to the PA, and then my RV starts, dilating, and I start to get this leaky tricuspid valve, and my wall tension is going up on the right ventricle, and I get some ischemia in the right ventricle, and ultimately I can lose output from the right ventricle, right? If there's enough of a clot, this can then lead into, right, if I'm not pushing forward enough from the right ventricle, my LV preload has gone down, and so my cardiac output has gone down. And so, this is the state of, what we call cardiogenic shock, where my cardiac output is not sufficient. And so, there is, of course, this systemic hypotension that can happen. Often, though, there's this big, gap between these two steps where I'm clamping down peripherally. Like if you've ever seen someone in cardiogenic shock, they're very clamped down to try and maintain that peripheral flow. But at some point, once I become systemically hypotensive, I'm going into this cardiogenic shock state. This is a big problem because systemic hypotension now feeds back onto this ischemic right ventricle. And this is known, this process of RV death spiral, because of the positive feedback that we see where the systemic hypotension worsens the RV ischemia, worsens the RV output, and these patients rapidly get worse. So, I keep saying this thing of RV strain. Well, this is RV strain, right? It's dilating, and I'm starting to increase this wall tension. This is what RV strain is. And we measure this with labs. And so, when I ordered the BNP, right, I'm measuring the dilation in my ventricle. I'm not measuring the volume status of this patient or trying to get a window into that. Instead, what I'm trying to see is, have I started to put strain on my right ventricle? And as I get ischemic, right, I start to leak troponin. And so that's why it's so significant that these two labs are elevated. And when they're elevated, it greatly increases my mortality. My mortality goes up 6 times. So by the time I get down to here and I get systemic hypotension, my mortality is, over 24%, maybe higher depending upon the rest of the details. So we can use a risk calculator. It can help us to identify high-risk people. I mean, there's some things like old age and chronic lung disease, cancer, and if they're hypoxic. If you want to check them out, you can look up the Pulmonary Embolism Severity Index, or PESI. There's also a simplified PESI, or SPESI. This is what we use in our hospital when a patient gets diagnosed with a PE. And what I really like about SPESI is it's not a really difficult calculator. There's not a lot that you could do it from a chart review, right? And so the nice thing about it is if you say yes to any of these questions, you're automatically high risk. And it's not putting a fine point on the risk, it's just saying low or high risk. And in this calculator, high risk is about 9% or so. So if you're over the age of 80, or if you have a history of cancer, or chronic heart and lung disease, or tachycardic, or if you're hypotensive, or if you're hypoxic. So both of these patients are, SPESI positive. They're high risk as identified by this, okay? Now, if you said no to all of these questions, then the risk is much lower. And we use these risk categories to help us make these decisions. The risk of the PE, it really comes down to how much strain is put on my right heart. And so a low-risk patient has no RV dysfunction at all. A submassive PE does have RV dysfunction, and a massive PE is not about the size of the clot. Instead, it's about if the patient is hemodynamically unstable, okay? So you can see a low-risk PE, there's normal cardiopulmonary system, no elevation in those biomarkers. My troponin, my BNP, my lactates, those things are all normal. Submassive PE, on the other hand, I start to see an elevated troponin. My RV starts dilating on echo or CT. My RV is hypokinetic on an echo. My RV systolic pressure starts rising. Now it's over 40. Troponin and BNP can be elevated, and I start to see electrical changes like the ones that I mentioned. The right bundle branch block, the interoceptal T-wave inversions, or the precordial leads like I call them. And finally, we have the massive PE. And so the massive PE, the patient is hypotensive, or they're needing vasopressors. And in some cases, this is not very common, right? But sometimes we can see a profoundly bradycardic patient. And so any of these things for most people, we would call that a massive PE. Or if they were a cardiac arrest or a resuscitated cardiac arrest, we would also categorize those as massive. So when we look at the prevalence, the bulk of the patients with the PE, 55%, they have a low-risk classification, no RV strain. And so you can see that the mortality here is low. It's like 1% or less. That's fine. But the high-risk patients, they have a much higher risk profile. So this is only 5% of PE patients, though. You could see, though, this submassive group of patients, they have something like an intermediate risk profile, but they make up 40% of PE patients. And so you could see that this mortality, it ranges, 10, 24%. And a lot of these trials that I'm going to talk to you about, and a lot of these approach concepts, they're taking recognition of the fact that a patient with a 1% mortality, maybe we shouldn't manage a patient with a 20% mortality the same way, right? Those are fundamentally different people, and maybe we should approach them in a fundamentally different way, okay? So if I went back to my, little diagram, what I would say is the low-risk patient is up here, right? They have a blockage, but it's not putting strain on my right ventricle. There's this big intermediate risk category, the submassive PE, and once I become hypotensive, now I'm in the massive PE classification. And so hopefully what we'll start to think about is that this intermediate risk is we used to manage it the same way as this, as the low-risk PE. This may actually be a window, though, that we can prevent patients from progressing to the high-risk state, okay? And so that's what a lot of the newest research and all these clinical trials have been looking at, is really approaching these intermediate risk patients. When we treat a PE, the mainstay is anticoagulation. We all probably know that. And in some cases, yes, when you diagnose it, in some cases with a high enough clinical suspicion, if I just had that patient in the beginning, the 26-year-old, she's on oral contraceptives, acute onset of shortness of breath, I would start her on anticoagulation before I even got a CT scan, right? And this is an excellent resource. The CHEST sets these guidelines for how we manage venous thromboembolism, and so if you're interested, excellent resource there. Now, you're probably aware that we also push lytics, right? I've already mentioned it. And fibrinolytics are only for those high-risk patients. And so this is from CIRC or AHA. And so they, say class 2 recommendation 2A, level B recommendation, that lytics should be considered for these patients with massive PE, right? The ones that are hemodynamically unstable. And so now, let's talk about these submassive ones, okay? Like, could I push fibrinolytics on a submassive PE? And there have been trials that have looked at this. So if you've ever heard of the PITHO trial, this was a randomized control trial looking at intermediate risk profile patients, right? Not massive ones, not low risk. And they pushed systemic lytics. And they did see that it had, that patients that got systemic lytics had much lower rates of hemodynamic decompensation, right? So they did not progress to the massive PE. The issue with this study, right, is that there was not a difference in mortality that was seen between these two groups. And as we would expect, these patients that got systemic lytics, they had significantly higher rates of, major bleeding complications, head bleeds, things like that. There were other trials, like the MOPPET trial. This was a prospective randomized control trial, a much smaller patient group, again, of these intermediate risk PE patients, and they were given kind of a modified dose. Instead of the full dose of lytics, they got like a half dose. And this showed a reduction in the PA pressure, right? So after 2 years, they still have lower right-sided heart pressure than the ones that didn't get it. This study wasn't powered for mortality, and so this has really not changed practice, although sometimes we do talk about and consider giving systemic lytics. But at the end of the day, the bottom line is pushing fibrinolytics is for the hemodynamically unstable massive PE. Okay? I've mentioned this several times already, but we also have these catheter-directed techniques. We have catheter-directed thrombolysis and catheter embolectomy. So here is a picture of a catheter embolectomy that was done that retrieved a significant amount of clot from a patient. And these therapies have shown improvement in what we call surrogate endpoints, not mortality. None of the trials have been powered for this. They're showing a decrease in the right ventricle's dilation, and they're showing a reduced progression to pulmonary hypertension. Like just to give you some of these trials, we have one catheter that's a catheter-based lytics, the ECOS catheter. So the Ultima and Seattle 2 trial, they both looked at using this catheter. So here's Ultima, small patient group using this catheter that's advanced into the pulmonary artery, and it has ultrasound with it to help hopefully break this clot up. And this did show, right, that it improves the RV dilation. Okay, so this is improving one of the things that we want to improve, but this is too small, right? Only 59 patients to comment on mortality. Here was another trial. This was the Seattle 2 trial. Still only 150 patients, and these are both with high risk and intermediate risk profile PEs. And they also showed an improvement in RV to LV dilation, but again, it's not powered really for mortality. We have a lot of other trials looking at these catheter techniques. So we have a catheter from Inari, and we have a catheter from Penumbra. So the Flame trial and the Flare trial, they both were looking at the Inari catheter, the FlowTriever, and Flame was for the massive ones, Flare was for these other ones, these submassive ones. And there's a Flame database that's still maintained, but you can see that, you know, the patient population is too low, only 53. It is improving things like the cardiac index, right? That cardiac output that we care so much about, the heart rate, the mean pulmonary artery pressure. It's improving these other things that we look at, but you know, here's the Penumbra catheter. This is the Extract PE trial. Again, not powered for mortality, but it's consistently showing that when we relieve the clot burden of the pulmonary vascular bed, we improve the RV to LV dilation. Okay, so this is what all the research is being done on right now, is trying to answer this question about will these only improve these surrogate endpoints, or will they show mortality benefit? Okay, I mentioned VA ECMO, or veno-arterial extracorporeal membrane oxygenation, and so for example, we have a patient with a resuscitated cardiac arrest, patient in refractory shock despite using these other things, like maybe we push lytics, maybe we took them for a catheter technique, maybe they're on multiple pressors, maybe we can't give them systemic lytics. Although, you know, that's like with a big healthy asterisk, because if you have a contraindication to getting systemic lytics, you know, the bleeding risk profile of a patient on ECMO is high. And so this is obviously a case-by-case basis, but in an acute PE, this is a very attractive thing. Okay, so I'll just briefly explain. What we're doing is we have two catheters, one venous catheter and one arterial, and typically we're using femoral access, not exclusively, but typically. And so we're pulling blood out of the venous system. And so the reason that this is so helpful in an acute PE is that all that venous blood that's coming back to that right ventricle and dilating it and causing all this RV strain, it's now immediately decompressed the RV, because we pulled all this blood off, we're putting it through this oxygenator, and we're returning it back through the arterial system. And so in addition to decompressing that right ventricle, we're also giving what I call mechanical support. And mechanical support is basically cardiac output, right? And so we're augmenting the cardiac output and oxygenating the blood and letting the RV rest a little bit, okay? And honestly, it buys us a little bit of time. ECMO is not an end point, but it is a way to get somewhere that you want to be, okay? A few other notes about PEs. So when we interrupt the normal physiologic response, right, that tachycardia, that increased contractility, all the, you know, the adrenergic responses that we see, it really impacts our patients. So here was a study looking at patients that were getting an embolectomy done, and once they got anesthesia induced, right, they're going to be placed on the vent. Almost 20% of the patients in this trial had a cardiac arrest. In this other study, you can see that the patients, again, very high prevalence of precipitating a cardiac arrest by inducing general anesthesia. So, you know, when we say, like, go to intubate one of these patients, a PE patient relies on all these compensatory mechanisms, the tachycardia, the adrenergic response, and what happens when we, you know, do our RSI is we immediately drop the venous return to the right heart. And a patient with acute right heart failure is what we call preload dependent. And when you take away their venous return abruptly with anesthesia like this, it can lead to profound hemodynamic instability. It can cause them to have a cardiac arrest. And I would say that this does not just mean, right, anesthesia, right? So, like, imagine if I came upon my patient here and I said, gosh, you're so tachycardic, your rate is 130, I need to slow that down. And I start giving you beta blockers. Well, I can do the same thing. I'm interrupting your physiologic compensation, and so I've seen patients in cardiogenic shock where this happened and it precipitated an arrest. Okay, so we should be very careful about taking away the patient's ability to respond. And when we end up having to place a patient like this on the vent, we might approach it very carefully. So like maybe we go ahead and put a venous and arterial sheath in place in case the patient codes, and we can rapidly cannulate them for ECMO. Okay? So, you know, this is me. I'm done talking about the PE management and all this stuff, and I'm going to pivot now to talking about kind of this hospital program that we've created. So a patient gets diagnosed with a PE, and this little journey here is complicated, and it's really poorly coordinated. So what I have sketched out here is there's things that happen out in the community, there's things that happen here acutely in the hospital, and there's things that happen afterwards. So, you know, the patient's at home, they're short of breath, maybe they start Googling, like, why am I short of breath? Maybe they go to their primary care, and at some point they end up getting a scan that finds that they have a PE, whether it's a CT angiogram or a VQ scan. And they get admitted to the hospital, and maybe we do ECMO, maybe we do a catheter embolectomy, but at some point, right, they have to go back home. And that's really the goal. And when they go back home, like that 26-year-old, she needs follow-up, right? She needs to be screened for hypercoagulable conditions. These patients need to be screened in many cases for post-clot syndromes, like CTEP, right, or chronic thromboembolic pulmonary hypertension. So, you know, it's not uncommon for me to see a patient who had a PE 5 years ago, right, and they don't even really understand what happened, right? So, you know, coordinating between these three phases is really inefficient. It's not well coordinated. The quality is really erratic. So, like, I might see somebody who had a clot 5 years ago and they're still on anticoagulation, and I'm like, why are you on this? And they're like, that's not a good thing, right? So, there needs to be a place that we could take care of these patients. And I think that this is a direct result of how we are structured in medicine. Okay, you're the hospital, and like we're the PCP, you're cardiology, and I'm pulmonary. And so we have these like different domains, these different disciplines. Of course, that's just how medicine works. But the solution is to take all the pieces that we need to take care of my PE patient and put them in one group. Okay, so this group is called PERT, Pulmonary Embolism Response Team. It's a multidisciplinary team. You can see I have IOR, pharmacy, cardiology, ER, nursing, pulmonary critical care, internal medicine, and more. Right? There's a bunch of people that I tricked to sit on this committee with me, and not all of them respond. I'll talk about how it works, but you know, we can come up with a coordinated, comprehensive approach to PE management that honestly really lets us give really individualized care. Okay, and so what I would say is that the end result is better for the patient. Okay, they get better outcomes. We're going to lower the total cost of care for a lot of reasons that we don't have to get into. It's better for the team because we know, okay, when we get a PE, we call Jonathan and his team, and they will give us the options. Right? There's not all this uncertainty about, is this patient a candidate for X, Y, or Z? I'm not getting consulted on a PE patient a week into their hospital stay because they can't get weaned from oxygen, right, for example. It's a better patient experience because now they're getting the benefit of what's the most current evidence-based solutions, and they're getting a lot of eyes that look in on their case. Because what we're doing is standardizing care, right? Not all care needs to be standardized, but having things standardized, it really reduces complexity, okay? It makes us more efficient. It makes the inpatient treatment decisions a lot easier to make. We improve time to anticoagulation, and we expand the use of these advanced therapeutics for patients that need them. So the catheter techniques and et cetera. And you know, like this is obviously going to be hospital dependent, but like in my hospital, the culture was put them on a heparin drip because they have a PE and we'll wait. Well, that waiting process might take a day, like 24 hours or more, for them to reach therapeutic anticoagulation. In most cases, we're stopping the heparin and just putting them on Lovenox, and they're getting time to anticoagulation much quicker. We're connecting them with outpatient care and hopefully reducing readmissions, okay? We're giving really individualized treatment decisions, and this is a big one, is when you put everything together like this, you can start data collection, you can look at your outcomes, you can compare it to your sister facilities, and you can support clinical trials, okay? So at my hospital, this has been about a 3-year process, and so what we've done is, like I got all these people on this committee from all these different specialties. We made guidelines for how do we activate PERT, how do we provide clinical care. We have a dashboard where we track quality outcomes and the metrics that we really care about, so that we can see, well, what are our outcomes? When we started this process, it was hard to answer. How does that patient that got the catheter embolectomy, how do they do afterwards? And that's scary that we can't answer simple questions like that. And so unless you have a system that's trying to track and improve outcomes, I'm sure that your hospital will have the same problem that mine does. We are on the National PERT Consortium, which is an organization that helps set management standards. And I'm on the member of the education committee with them. And because of our PERT program, we were selected as a clinical trial site for Peerless 2, which is a clinical trial for catheter embolectomies. And so we're randomizing people with not just intermediate risk, but intermediate high risk, which is a very, like the highest of the high intermediate risk profile patients. So this is the trial, and so yeah, it's just catheter embolectomy for intermediate high risk PE patients. And this is really my vision, okay, is that it's not just my hospital, right, but we have started creating this network where, at Tier 1, we have an IR department that, they have really done very complicated cases for these embolectomies. We can cannulate people for ECMO, the program administration, right, where we track data and stuff. That's located at my hospital. But we have other hospitals in our system that have IR departments that can do these things, but maybe they don't have the capability for ECMO, for example. Well, that would be a Tier 2 site, and a Tier 3 site would be like where we can admit a patient, we can get them an echo on a routine basis, but like they don't need these other things, okay? And so then we might have a freestanding ER where they can give them lytics, they can start anticoagulation, but they can't admit them, they can't get these echoes and things like that. So, often when we think hub and spoke, what we're really meaning is like a big funnel. Everything goes up to Tier 1. And that's absolutely not what I'm saying, right? I think that that's a terrible way to do it because it just sends everything upstream. And it's gonna clog things up at the Tier 1 facility, and it's taking things away from Tier 2 and 3. And so wouldn't it be better if you had a patient that was at the freestanding ER that could just come here? Maybe they're not a candidate for ECMO. We can get them their embolectomy done and offload the burden on the downtown hospital that I'm at. Okay, and so that's kind of the idea, and we're working through these details at a system level right now so that we have a system level PERT where we have standardized approach to PE management. And so this is really the thing that I wanted to tell you about, right? It's like, as a PA, right, like we can create programs that change how the entire hospital system approaches a disease state. So like if you're at a facility or a different hospital system than THR, or if you're in THR, and this sounds like something that you would be interested in, please reach out to me, right? And I would be happy to tell you my experience, lessons learned, connect you with the resources that you need, because it has helped our relationship with the hospital quite a bit. And I think honestly we're just doing the right thing for the patient, which is what we should be shooting for at the end of the day. So like, for example, when I have a patient that's over here at Tier 3, I want to see that they have right heart dysfunction before I consider moving them, right? And so their RV is dilated or it's hypokinetic. And then we look at, if 2 of these 3 categories, hemodynamics, biomarkers, and respiratory system, if 2 of these 3 categories are positive. So it's not just that they're tachycardic, it's not just that they're tachypnic, but it's that they're having, at least that they're, tachycardic and they're needing quite a bit of oxygen, and they have right heart dysfunction. Like, okay, that's somebody with a pretty decent amount of risk associated with that PE, and that doesn't mean that we have to transfer them, but that means let's have a conversation about, should we move this patient? Are they a candidate for something else? Because they might not be. And just having that conversation is helpful in and of itself, because we get to, I think, give a little reassurance to these outlying hospitals that aren't the tertiary site to say, yeah, no, we're not going to do anything but anticoagulate them. Because nothing is worse than seeing a patient that got transferred that you're like, yeah, sorry, your car is 30 miles away, but we're just going to start you on an anticoagulant and discharge you tomorrow, which is something that happens a lot, or happened a lot before we had PERT. There's a lot of benefits, and we're kind of running up on time because we had the technical difficulties, but when we're all collaborating and getting standardized care and tracking outcomes, obviously that's going to help us improve the clinical care, having an interfacility transport system lined out. We have financial benefits, right? Because we are identifying more patients that get these advanced therapeutics, and we're helping to keep things contained. We're not just moving patients reflexively and repeating all the workup. And it helps support our community hospitals. And there's network effects, right? You become the place that PEs come. And you help create this halo effect that I'm calling, right? Where I work hand in hand with the cardiogenic shock and ECMO service lines because these things are all interrelated, okay? And so what we're currently working on, right, is where we might have a patient at one of these smaller community hospitals with a massive PE or submassive PE that we decide, hey, let's cannulate this person for a VA ECMO. And so we'll go to their hospital, cannulate them, and then bring them back, okay? And working together like that, I think, is ideal. So this is my family and my dog, and so thank you so much for your time. Taking care of PE patients is complex. There's a lot of specialties involved. Integrating and standardizing care across your hospital system, I think it really helps improve care and the experience for your staff. And I think a big part of this is taking care of that patient across the whole care cycle, right? Out in the community, acutely in the hospital, and reintegrating them back into the community. And so I'll just give you the resolution of these cases. So the 26-year-old with PCOS, so she got admitted, we took her to IR for a thrombectomy, and she unfortunately sustained a cardiac arrest on the table. So we gave her thrombolytics, and she got cannulated for VA ECMO, and on hospital day 1, she got taken back while on ECMO, had an embolectomy done. Hospital day 4, she's decannulated from ECMO. Day 7, she's extubated, and on day 25, she got discharged to inpatient rehab with good neurologic outcome. This is the ideal. And the reason that I included this case is to say, taking care of these people is complex, right? And so just trying to have the ER send somebody to IR for a procedure, it's not just a procedure, right? In a lot of cases, we need to have a conversation. And so we had things lined up in place because this girl was so teetering on the edge. And that's the ideal. And the case number 2, that 75-year-old gentleman, remember he had hypertension, hyperlipidemia, he had a DVT before, he also had a submassive PE. And so for him, he went straight from the ER to IR, got a thrombectomy, and he never even came to the ICU. This is typically absolutely a patient that would have been started on heparin, taken to the ICU, and would have probably had a 6-day hospital stay. But by hospital day 1, he's weaned to room air, and he goes home on hospital day 2, right? So we use this program, we reduce hospital length of stay, we're reducing ICU length of stay, we're expanding the use of these techniques. So again, I think this is a great system, right? And if you have interest in it, please reach out to me. We don't have time to get into the dashboard, but here is, to give you an idea, we track, okay, well, how do things break out? And so 15% of all the PEs that we have, they end up going for a thrombectomy, okay? Or thrombolytics through a catheter. And you can see our breakdown. We have a 7.7% prevalence of high-risk PE. And we track our activation time, and we track all these metrics that predict cardiogenic shock. So when we can track things like this, you can answer questions in a very different way. We can see, our PERT activations are going down. We need to go and remind everybody about PERT again, okay? If you're interested, I would encourage you to check out the 2019 European Society Guidelines. we use these definitions for PE severity. The low risk, intermediate low, intermediate high, and high risk PE. CERC recently put out this paper on surgical management, right? So it talks a lot about cardiopulmonary bypass and ECMO management for these people. If you are interested in PERT, I highly recommend at least Google PERT Consortium, but they put out lots of literature about management, like society guideline management. And then in just like a higher strategic kind of way, this concept of creating this PERT, it's what's known as an integrated practice unit. And so if you know anything about business, you might know about this guy, Michael Porter, who's like, he created a whole field in the business world. And he has moved on into healthcare where he's talking about creating these multidisciplinary teams like PERT around a disease, not around like, well, I see all pulmonary things. Okay? Here's the website, PERT Consortium. I encourage you to check it out. And like, we don't have time to get into it, but here's how we activate and like what kind of things happen. And here's our big treatment algorithm. So with that, I'll stop because I'm right up against the time. So thank you so much for your time.